My name is Casey Schumann, and I'm a PGY1 pharmacy resident at Wake Forest Baptist Health. Today, I'll be presenting correlation of engraftment in time from melphalan administration to stem cell infusion. My co-investigators and I have no disclosures. The coordinating site for this project was Wake Forest Baptist Medical Center, which is an 885-bed academic medical center located in Winston-Salem, North Carolina. We have a designated comprehensive cancer center by the National Cancer Institute, and we perform over 120 stem cell transplants annually. This project focused on autologous stem cell transplants, specifically in patients with multiple myeloma. High-dose chemotherapy followed by stem cell transplant is considered the standard of care for these patients. The high-dose chemotherapy or preparative regimen of choice for multiple myeloma patients is melphalan. Melphalan, which is an alkylating agent, is an ideal preparative regimen due to its myeloablative effects and minimal extramedullary toxicities. Patients commonly receive 200 milligrams per meter squared, but those patients with renal impairment or advanced age will receive a dose reduction down to 140 milligrams per meter squared. Melphalan is given as a 30-minute infusion and is typically given the day prior to the patient receiving their own stem cells back. While melphalan's utility as a preparative regimen has long been defined in the literature, the timing of its administration in relation to the infusion of stem cells is not as clear. In previous studies, melphalan was given 1 to 2 days prior to the infusion of stem cells. However, some institutions are shortening this time frame and administering cells at earlier time periods of 12 to 24 hours. To our knowledge, there is no evidence to support this earlier time frame, and there are no studies in the literature that make a direct comparison between these time frames and the impact on patient outcomes. To briefly orient you to the transplant process, patients begin the process anywhere from weeks to months prior with mobilization of their own stem cells with growth factor and plerixafor. Once their white blood cell count is high enough, their stem cells are collected. Patients receive melphalan the day prior to transplant, which is considered day 0, and 5 days after the infusion of stem cells, patients begin growth factor therapy, which is continued until white blood cell engraftment. The purpose of this study was to determine if the infusion of stem cells within 12 to 24 hours impacts time to engraftment. This was a multi-center retrospective chart review study that included patients who received a stem cell transplant at Wake Forest Baptist Health and the University of North Carolina. The policy at Wake Forest Baptist Health is to wait at least 24 hours following melphalan to infuse stem cells, while the University of North Carolina allows for earlier administration. At this institution, cells are typically administered anywhere between 12 to 24 hours. The study included patients who received a stem cell transplant between January 2016 and September 2019. Each institution's transplant registries were utilized to identify patients. Patients were separated into 2 cohorts based on the timing of stem cell administration in relation to melphalan infusion. For statistical analysis, categorical data was analyzed using chi-square or Fisher's exact tests. Mann-Whitney U and Students t-tests were used for continuous data. Our primary objective was to determine if the infusion of stem cells within a shorter time frame impacts time to white blood cell engraftment. Our secondary objective was to determine if this shorter time frame impacts time to platelet engraftment and incidences of mucositis. The primary outcome was absolute number of days to white blood cell engraftment. Secondary outcomes included absolute number of days to platelet engraftment and incidence of mucositis within 30 days of transplant. Definitions consistent with the Center for International Blood and Marrow Transplant Research were utilized. White blood cell engraftment was defined as an absolute neutrophil count of 500 or greater for 3 consecutive days. Platelet engraftment was defined as a platelet count of at least 20,000 for 2 consecutive days without platelet transfusion support. To determine mucositis, we used both nursing and provider notes for documentation. We also used prescriptions for mucositis mouthwash or viscous lidocaine as surrogate markers. We included adult multiple myeloma patients undergoing autologous stem cell transplant for the first time who received single-agent melphalan as preparative therapy. Patients' cells were mobilized with growth factor with or without plerixafor, and patients had their stem cells collected from their peripheral blood. Patients with CD34 cells per kilogram counts of less than 2 were excluded. Patients who received chemotherapy to mobilize their stem cells were also excluded. Over 300 patients were included for analysis. Looking at the baseline characteristics, our most commonly encountered patient was a Caucasian male in his early 60s. There were more African American patients in the second cohort, and patients in this cohort were also slightly younger. Majority of patients were mobilized with both growth factor and plerixafor and received melphalan dose at 200 milligrams per meter squared. There were a greater proportion of patients in the second cohort who were mobilized with growth factor therapy only. The CD34 cells per kilogram count was roughly 5, which is within goal for patients with multiple myeloma. Looking at our results, patients who received stem cells more than 24 hours after melphalan had a faster median time to white blood cell engraftment of 11 days. However, the median time to platelet engraftment was longer in this group at 20 days. Mucositis did differ between the groups, with more patients affected in the greater than 24-hour cohort. In conclusion, our study found earlier white blood cell engraftment in those patients who received stem cells more than 24 hours after melphalan infusion. With this being a multi-center study, one of our greatest limitations is practice differences between institutions. For example, our institution performs outpatient stem cell transplants, while our partnering institution admits patients for the transplant process, which could have impact from a documentation standpoint. There's also some variability between our institutions in regards to our mobilization regimens, as we mobilize nearly all patients at our institution with growth factor and plerixafor. Another limitation to our study is that our cohorts were not matched, which resulted in baseline characteristic differences that could potentially confound our results. So moving forward, we plan to perform additional analyses to confirm our results, and we also plan to include more patients in our analyses from an additional academic medical center. We also hope to expand our criteria to include more diagnoses beyond multiple myeloma to see if our results remain consistent when melphalan is used in combination with other preparative agents. I'd like to thank my research team for their contributions. Here is my presentation objective and assessment question. Thank you for listening, and please feel free to reach out to me via email with any questions.